Hi everyone, my name is Blake Shook. I'm a speech language pathologist here at Success Rehab. I'm here with Shannon.
Hi, I'm Shannon Noggle, and I'm also a speech therapist here at Success Rehab. And today we're going to talk to you about dysphagia and your importance.
Okay, so what is dysphagia? So it's basically the medical term that we use to describe any swallowing abnormalities or if a person has difficulty while they're swallowing. In some cases, it may be painful for the individual, and it doesn't necessarily have to be painful. But in most cases, when people present with dysphagia, pain's going to accompany the dysphagia. In dire cases, swallowing is generally impossible, and people will need alternative forms of nutrition such as NG tubes. Dysphagia is more common to occur as individuals age, but it can occur at any age, and it's especially important to be aware of it here because a lot of our clients are susceptible to developing or already have dysphagia due to having a previous history of a TBI or an ABI. Some of the typical symptoms associated with dysphagia include pain while swallowing, having this feeling of food being stuck in the back of your throat or kind of like a lump, drooling, hoarseness in the voice, food coming back up after swallowing, heartburn, weight loss, coughing, among others.
Okay, how do we diagnose dysphagia? Well, as a speech therapist, we usually do bedside evaluations or just a typical swallow evaluation with a client, usually at a meal or with a snack. But there's also two other tests that we can do. One is the modified barium swallow study or a video swallow. And this is where a client will be taken to the hospital and it's kind of like a live x-ray. So the client will drink a barium solution, which allows the speech therapist to see how the person is swallowing and how it's going down their esophagus into their stomach, and if they're showing any signs or symptoms of aspiration or penetration into the lungs. There's also the FEES, which we do not do here, but this is also another test where a thin, flexible instrument is inserted throughout the nose, allowing the clinician to see parts of the swallowing process.
All right, so how can we break dysphagia down into some different stages here? So dysphagia can be characterized based on one of two ways: the location that it's occurring in the body and the severity of the dysphagia. So the severity can be further categorized into mild, mild to moderate, moderate, moderate to severe, and severe dysphagia. And then similarly, we can put the severity grades onto the location, and we can either have oral dysphagia, oral pharyngeal dysphagia, or esophageal dysphagia. Oral dysphagia obviously is during the first part of the chewing process. This is when they experience difficulty chewing, breaking down food. A lot of times this is when people will have trouble with forming a cohesive ball of food, which we call a bolus, and they may have trouble initiating the actual swallow. They could have trouble with their tongue movements. They could have excess saliva. So things about that nature is what we're concerned about in the oral dysphagia stage. The oral pharyngeal dysphagia stage, this is a very quick stage that is concerned with initiating the swallow. So this is just right in the back of the throat. If somebody has deficits in this stage, they will mainly be having difficulty actually initiating that swallow. And then after the swallow is initiated, there's the esophageal phase dysphagia, which is difficulty passing the food down through the esophagus into the stomach.
Okay, what are related dysphagia complications? So pretty much the number one is aspiration. This is where any food or liquid enters your airway and goes down into your lungs. So aspiration pneumonia is one of the biggest things that for people that have dysphagia. So again, when someone aspirates, food or liquid enters the airway during an attempt to swallow. Sometimes when the person continuously aspirates, aspiration pneumonia can occur due to bacteria entering the airway. There is a thing such as silent aspiration, and this occurs when people are aspirating, but they actually don't show any visible signs or symptoms of aspiration. So somebody can be aspirating, but they're not going to be coughing, throat clearing, or anything like that. Usually if someone is silent aspirating, you might see they might develop a fever, have trouble breathing.
Watery eyes, that's usually a pretty...
Also, let's see, so malnutrition, when people are unable to swallow adequately, they may eat less and thereby decreasing their overall nutritional intake. And also choking. So some people with dysphagia get food stuck in the throat, and food can block the airway, and people will be unable to breathe. And then that's when we need to perform the Heimlich maneuver.
Which I have done a few times in my 3 years of working here. I would say definitely aspiration and choking are the biggest complications we have to look for in a rehab facility like Success. We will be going over how to thicken liquids and diet guidelines and such to try to avoid aspiration as well as avoid some of the choking. So let's just get into that. So what are the diets like? So it's up to the discretion of the speech-language pathologist to determine the correct consistency regarding the food and liquids. It's completely different for every client, so it has to be an assessment process, and the SLP has the expertise to make the decision. Not all individuals with dysphagia will experience it the same, so it's important to be aware of all of the different consistencies available. On the right side, you can see the IDSI framework. We loosely use this at Success. This is the common method that SLPs use to determine appropriate consistencies across the board. In many different settings, this is what's frequently used. Drinks tend to become thicker when a cornstarch-like solution is added, which we call thicket. The more that is added, the thicker the consistency becomes, which therefore makes it easier to swallow. Sounds a little bit counterintuitive that it's thicker, so it's easier to swallow, but the thin liquids have a much easier time entering the airway because they're thinner. They move a lot faster. So if somebody's trying to swallow, or even if they're not trying to swallow, they're just holding it in their mouth, thin liquids can run right to the back of the throat a lot quicker and enter the airway than a thick liquid. So with foods become cut up the further that you move down the pyramid. So you can see that a lot of the foods and drink consistencies tend to overlap. Foods eventually need to be blended to achieve a more water-like consistency if you have to get to that level. And again, this is completely dependent on the individual, and it's up to the assessment process of the speech-language pathologist.
And some of the clients here, most of the clients at Success are on regular diets, but we do have ones that have specific needs. So if you see like their meal is chopped up into small pieces, that's the chop diet. We do have one client that is on a puree diet, so everything will be blenderized. And also with the thickened liquids, we have a few clients that are on the thickened liquids. And to go back to what Blake was saying, we do use, so we don't use thicket here. We don't use the cornstarch powder. We use Simply Thick.
Yes, Simply Thick.
Which is so much easier to use, which we'll address in one of the slides of thickening liquids. But like over the years, so I've been doing this for almost 21 years, and the powder is not the best thing to use because after you stir it up, after it sits for a while, it turns into wallpaper paste. So the Simply Thick is so much better because you just pump it into their drinks, you stir it up, and it stays that consistency, and you don't have to worry about turning into anything thicker and causing any other issues.
Yeah, we just switched from that actually not too long ago. Right before Shannon started, we had the powdery cornstarch stuff that I mentioned.
Yeah, it's a lifesaver. It's
yeah.
Much easier.
Much easier, much safer for the clients.
Oh, here we go.
Here we go, more with the liquids, but it's basically what we kind of just covered already. So obviously, thin liquid, there's no thickening in it whatsoever. It's just the completely normal liquid without any additional additives. Slightly thick, you can see that it runs a bit off the spoon very slowly in kind of like droplet forms, as you can see with the nectar there. Honey thick is a bit thicker than the nectar. It runs off a bit more slowly, and it basically is what it says. It's like the honey-like consistency. And then pudding, we don't have anybody on pudding thick here. This is the thickest, and at this point, if somebody's on extremely thick, then they probably have additional diet modifications that we need to be aware of. And if somebody would be on pudding thick, the staff would be directly informed. But as of right now, for the intents and purposes of your role as staff and safe swallowing strategies, nectar and honey are the main two, and thin, that we should be taking into consideration.
I think there's only a few clients here that are on nectar thick, nectar or mildly thick liquids. Everyone else is on thin. All right. Okay, next slide here is pretty much what we were going over before with the different types of diets. So regular, we have soft and bite-sized, minced and moist, pureed, and then liquidized.
All right. Another big thing as your role as staff is not necessarily performing the oral care, but encouraging oral care, encouraging good oral hygiene practices. Bad oral care can 100% lead to aspiration pneumonia. If so much bacteria and biofilm builds up within your mouth and it's not clean, once you're swallowing liquids or food or anything for that matter, even your saliva, if it's going in the back of your throat, it can easily enter the airways with somebody that has dysphagia. And if that is contaminated with bacteria and viruses and other things, that can cause the aspiration pneumonia. So it's crucial that as staff, the oral hygiene practice is such an important step because it can reduce the bacteria, aspiration pneumonia, as well as other conditions. So during oral care, it's important to make sure that the individual is sitting upright or stands if it's easier. They need to remove all the remaining food particles within their mouth. And that actually brings me to another thing with pocketing. A lot of the clients here will tend to pocket some food, so some of them will need some reminders to consistently chew and take sips after and during their eating. Using a toothbrush whenever possible, brushing your teeth, your tongue, and your gums, rinsing mouth with water, and repeating frequently as needed, at least twice daily. We try to get our clients to do this. We have different posters hung up in each of the off-site houses to help educate staff with oral care, but if you have any remaining questions, we are here to answer them for you.
Okay, what is my role as staff? So you will probably see in the houses or in the client's binders safe swallowing guidelines. So the clients here that are either on altered diet and liquids, or they can be on a regular diet and thin liquids, but they do need verbal cueing to follow certain strategies while they're eating and drinking to prevent coughing, throat clearing, and possible risk of aspiration.
And just to maintain their attention. A lot of them have so much difficulty with just maintaining attention, and that's a big reason a lot of them are classified as dysphagic.
Yes. You will notice we do have a dysphagia room at Clymer for people that do need that extra supervision during meals and that verbal cueing. However, they don't necessarily have to be in the dysphagia room during meals, especially if they're at the house. If they need someone, staff, to sit with them and give them that direct verbal cueing. There are a few clients that do not live at Clymer that do require these strategies and cues. So we're going to go through these. So you'll see a list. So the first one, most important, always sit upright as much when you're eating and drinking. We do have some clients that are in wheelchairs and they tend to lean to the one side. You want to encourage them to sit up as much as they can during their meal. Small bites and sips. This is probably one of the most important strategies to use. One bite at a time, one sip at a time. Usually I recommend bites to be like the size of a quarter. No bigger than that. I know some clients tend to be impulsive and they want to take big chunks of food off their plate and shove it in their mouth. We don't want them to do that.
It is a TBI facility, remember.
Yes, impulsivity. And also with drinking, yes, they want to take one step at a time. There are some clients that need to use a straw for drinking, especially if they have fine motor skill issues. But then there are clients that they're recommended not to use a straw, because if they do have a swallowing issue, the thing with the straw is if you can suck in too much liquid, and if you're not ready to swallow it, it's going to fall back into your airway, and then boom, you're going to aspirate and start coughing. So oral care necessarily doesn't have to be before and after meals unless you have somebody that has like a pretty severe case, but as long as the clients are doing oral care, in the morning and in the evening. Maybe at the house, I recommend, like staff that's at the houses, like after they eat, recommend maybe for them to floss, like especially if they have food stuck in their teeth. So along with the small bites and sips, taking one bite, one sip at a time, always important. Alternating between liquids and solids. I try to encourage this as much as I can, and sometimes it's very hard to, so as far as eating and drinking is such a normal habit for us, like we're so used to doing it, and we don't think about it until we actually have a problem where we have to focus and concentrate on what we're doing. So usually I will recommend like take 2 or 3 bites, and another thing, make sure you're chewing the food up completely before you're swallowing, and then wash everything down with a liquid. There is one client that he constantly needs cues to do this because he won't do it. He'll just keep eating his food and not take a drink. So you have to put the cup like in front of him and cue him, here, you need to take a drink now to wash everything down. So that's important. And also lastly, just monitor coughing. If someone would start to cough like during their meal, just tell them to take a break and then start again. If it's something that becomes pretty severe, then I would just stop the meal altogether and just wait a little bit. But definitely report any issues that clients are having at meals. If you see that there's been like a decline or a change in their habits, or just when they're eating, if they're exhibiting like a lot of coughing when they're eating or drinking, then definitely report it to your supervisor or nursing, and they can report it to us so we can investigate further.
Yeah, in addition to reporting to your supervisor and nursing, also make sure to document it. You have to write an FYI or an occurrence report depending on the scenario. It'll be a little bit different if you have to write an occurrence or an FYI, but that's also very important to do. All right, so for some feeding guidelines now. So just to ensure that the correct meal was provided, you would be surprised how often it gets overlooked. If somebody gets a whole meal and it needs to be bite-sized, that could be a huge issue right away. Using verbal instructions for the individuals when you're talking to them, give them eye contact. These are people too. Reposition the individual to be upright. Feed residents sitting at eye level, okay, maintaining that contact. Reduce any distractions in the environment. As I mentioned before, this is a really big thing with dysphagia, and some of our clients that are dysphagic have to sit alone at their respective tables due to impulsivity issues and due to attention issues. A lot of them can tend to forget what they're doing at the time that they're eating. They can forget what they're eating. They could fall asleep during it. I've seen that happen a few times. So it's just very important to reduce those distractions in the environment. If they need help with feeding, which some of them will due to dexterity issues, fill spoon about halfway with food. Back to the pocketing. That's when individuals hold some of their chewed food in the side of their cheeks. So make sure that each bite is swallowed after the individual ingests it. So make sure there's no pocketing going on. And then monitor for any signs or symptoms of dysphagia that you're noticing perceptually while you're eating or while your client's eating, and then report.
All right.
All right, that concludes our
We did it.
wonderful presentation. I hope you guys enjoyed that. If you have any questions, you can contact Shannon or me. I should probably put my stuff in there, but guess what? It's the same number. So if you have any questions about anything related to speech, language, cognitive functioning, swallowing, hearing,
Yep, you can email us,
communication,
call
we're
us,
here.
or also email us. Just our names, snoggle@successrehab.com or bshuck@successrehab.com.
Yep.
Okay,
All right, guys.
thank you.
Thank you.